Dear colleagues in Nicaragua, we are planning now with collaboration between the Ministry of Health in Nicaragua and the Palestine International Cooperation Agency in Palestine to implement a pediatric spine program, which is which would be a part of the residency program for all the residents who are having part of pediatric orthopedic, and it will be part of the pediatric orthopedic, the pediatric spine, which will include talks, lectures, and also clinical doing surgeries through our visits to Nicaragua. The lectures will be mainly concerned with the definitions, what is scoliosis, what is the pediatric spine deformity, types of it, how we can manage it, how can we examine it. So in the end of the course, in the end of the lectures, hopefully we'll have that all of the residents that are included in seeing these lectures will be fully oriented about diagnosing pediatric spine problems, what is the management, including appropriate examination, x-rays, lab investigations, and the options of management, whether non-surgical or surgical, and knowing in total the surgical management of scoliosis, how to think about it, how to think about the proximal and the distal anchors, how to think about how would you do it and the complications, and how can we decrease the incidence of complications for these patients in a specific situation like in Nicaragua. And afterwards, if the resident after graduation would be interested in scoliosis, he or she can have a fellowship in pediatric orthopedic or spinal surgery, including scoliosis management. This is our aim for this program, and hopefully we can succeed with you in implementing this program and having this service implemented in Nicaragua by you, local Nicaraguan doctors that are efficient to do this service in the future. Now for the first talk, it will be the first lecture, it will be about the etiopathogenesis of scoliosis. Scoliosis in general is part of the pediatric spine deformity, which is related to the lateral deviation of the spine with the Cobb angle on the coronal view more than 10 degrees. Kyphosis is also part of the pediatric spine deformity, but it is an anterolateral deviation of the spine, and it should be more than 50 degrees in the thoracic region, more than 20 degrees in the thoracolumbar region, and in the cervical region. Generally speaking, it might cause in the future, scoliosis is not a cosmetic problem as the myth might say. It is mainly a problem that might affect style of life, that might affect the chest and the viscera in the chest, like the lung and the heart. It might cause back pain in the future. Besides the decompensation when the patient stands, that uneven shoulders or uneven pelvis. And scoliosis is not just a deformity in the body of the vertebra. It's a process that will include, though the body of the vertebra is clearly the one which will be affected, but it will affect the ligaments, the disc, the muscles around, and even the spinal cord or spinal nerves. So it's a process which will increase with time, affecting the whole components related to the vertebra. As we can see here from the picture, this is, let us assume that this is the line of the patient when standing, and we can see a lateral deviation of the apex. We call it the apex. The apex means that the most laterally deviated vertebra, which usually are the first to be affected in scoliosis. And you see, it's not just lateral shift, it's associated with the rotation, as we can see from this arrow. And this means that with rotation, there is more of a lateral deviation, and it might affect the vertebrae proximally and distally to deform. It will be first a non-structural curves as a compensatory curves, but after no management, it might go to be structural curves and need management. As we can see here, the vertebral unit with the arrows that you can see, it rotates around its axis, as we can see here. You can see this vertebra is rotating, and we can see here how the vertebra rotates in the upper ones on this side and how the vertebra in the lower ones rotate on the other side. And because the rotation is very important, there is something called, we have a classification which is called Nashmo classification. What is that? It is what is the difference in the pedicles, in both sides of the vertebra, according to the severity of the rotation. How's that? So we have grade 0, that the pedicles are on the same distance from the midline, clearly seen. But grade 1, the apex, the pedicle on this side is rotated, it's rotated on this side, the vertebra, so the pedicle here diminish, and the pedicle on the convex side goes more medial. Grade 2, the pedicle on the convex side, on the concave side, nearly diminished, but still there is a trace, and the pedicle on the convex side is going more medial. Grade 3, the pedicle on the concave side diminished totally, and on the convex side it's in the center. And grade 4, the pedicle will go further beyond the central line. This is the rotation, and it's very important to know about that, because sometimes you have a patient having postural scoliosis, like children who just bend on their sides when they have an X-ray. How can you differentiate between this as a scoliosis, structural scoliosis, or just a postural kind of one with the rotation? If you see a rotation, so you would think more of a scoliosis, structural or pathological scoliosis. If you don't see any rotation, it's more of a postural one. Now there are types of scoliosis. The main types of scoliosis are idiopathic, which is the most frequent one, and in the idiopathic, the most common one is adolescent idiopathic scoliosis. There is neuromuscular scoliosis. As we can see here in the picture, we can see this child. He is decompensated, as we can see. You can see the level of the pelvis, you can see the level of the shoulders. Actually, he can't sit alone. As you can see, there is a support from hands from somebody. And you can see the curve here, and you can see the small scar indicating that this child had a history of myelodysplasia. You can see the curve, how it's severe. And the patient is decompensated and the pelvis is oblique. This is a CP, cerebral palsy, which we all know about. And you can see the severity of cerebral palsy with the inclination of the pelvis, and you can see the severity of the curve, and the patient cannot sit without help. So it's crucial to, even if the patient cannot walk, non-ambulatory patients, the sitting position is crucial for them, and treatment of scoliosis is part of it. Now there is syndromic scoliosis, like this patient with kyphoscoliosis, upper thoracic kyphoscoliosis associated with Marfan syndrome. You can see the indications that we have a diagnosis of Marfan syndrome. Tall patient, very tall fingers and other issues. And this child is having Larsen syndrome, so we need to follow up this child for scoliosis, for the probability of scoliosis in the patient with Larsen syndrome and having connective tissue disorders. Also, there is congenital scoliosis. Congenital scoliosis, like we see in these two pictures, it's subclassified to malformation like this one, you can see the normal vertebra is like that, having two pedicles clearly, and the vertebra is equal on both sides. But you can see with this one, there is a hemivertebra, what we call it hemivertebra, which is a creation of one part of the vertebra and no vertebra on the other side. So there will be a growth on this side and decreased growth on this side, which will cause with the future a scoliosis with the hemivertebra usually on the convex side. Otherwise, we have like this curve, severe curve, which is more than 100 degrees, and it's associated with what we call it malsegmentation. What is the meaning of segmentation? We can see that the vertebra is segmented. That means there is a space between one vertebra and the other, above and below, that is filled with the disc and can increase the movement of the spine, can cause the movement of the spine. But with a congenital anomaly that the child would have, for example, like this one, what we call it a unilateral bony bar, that is a bony fusion in one side of the vertebrae that will cause retardation of growth on this side, but there is still growth on the other side, which will cause severe scoliosis, as we can see in congenital. Of course, this is beside adolescent idiopathic scoliosis, as we have said. So the etiology means the factors that are causing the deformity. The pathogenesis means the mode of origin of the motor process. And pathomechanism is the sequence of functional changes that result from the pathological process. And we can talk about etiopathogenesis, which is the combination of etiology and pathogenesis. So the pathophysiology of adolescent idiopathic scoliosis, specifically for adolescent idiopathic scoliosis, it's more of a hypothesis until now, concerned with genetic factors, central nervous system factors, metabolic factors, biomechanical factors. For the genetic factors, until now, there is no clear-cut evidence of the genetic factor because it is multifactorial and there is a need of a lot of studies for that. But why did the people, the scientists think about the genetic factor? Because they realize that there is an increased risk of adolescent idiopathic scoliosis development in first-degree relatives, up to 11%, and higher rates of monozygotic twins, 73%, than dizygotic twins, which is nearly half of that. So there are studies now, well-known genetic and genome-wide association studies that will focus on association between single nucleotide polymorphism and traits or disease such as adolescent idiopathic scoliosis. These studies discovered a potential relationship between adolescent idiopathic scoliosis and axonal guidance pathway. Also, there is a suspected link between leptin body with the central nervous system development and asynchronous neuroosseous growth mechanism. That will be some retardation of the neuroosseous growth mechanism and with the leptin body deficiency. But no specific mode of inheritance is discovered yet, and it's more of a complex genetic disorder with extreme variability. But there is now something called ScolioCore, which is a test that is prognostic mainly, that will study the progress of the curve, but not the initiation of the curve. Here we can see that low body fat mass, low leptin level, which might go to tension neuroaxis tethering and might cause scoliosis for these patients. The prevalence of adolescent idiopathic scoliosis is at-risk population, which we mean between 10 to 16 years of age, is from 0.5% to 3%, with differences based on geographical location, ethnicity, and sex. Of course, for sex, females are affected much more than the males. And about location, geographical location, we can realize that the prevalence in North America, for example, is between 0.4 to 4%, but it increased much more in Spain and Europe between 0.7 to 7.5%, decrease in Asia from 0.5 to 2.5%, and decrease more in Middle East and Australia to nearly 2%. In 2010, a meta-analysis including data of 36 studies on adult-centered idiopathic scoliosis found a pooled prevalence of spinal curves greater than or equal to 20 degrees was 22 per thousand. Further, the prevalence of individuals who had been treated for scoliosis for surgery were 7 per thousand. If these percentages are applied to current population figures, more than 620,000 adolescents in the States would have adolescent idiopathic scoliosis. In a study that was done in 2012, over 5,000 patients in the United States were surgically treated for adolescent idiopathic scoliosis, which has a financial impact of more than $1 billion. And that is the importance of early detection of adolescent idiopathic scoliosis, especially in countries with limited resources. If you discover it early, if you had efficient management for it, it will decrease the expenses on the long future. Even it will improve the results of the patient related to this problem. Also, we'll talk about the relationship between adolescent idiopathic scoliosis and the pulmonary function, which is very crucial. And the vital capacity and the PaO2, it decreased as the severity of the thoracic mainly curve increased. No correlation between curve severity and loss of pulmonary function exists for other curve patterns like the lumbar and thoracolumbar. The majority of patients with large thoracic deformities, that means we talk about coronal cup angle more than 80 degrees, and 3D thoracic lordosis less than 20 degrees, and absolute apical rotation of more than 25 degrees, had moderate to severe impairment in pulmonary function. A cup angle of 50 degrees or greater at skeletal maturity is a significant predictor of curve progression and later decreased pulmonary function. What about the mortality? In adolescent idiopathic scoliosis, increased risk of death from col pulmonale and right pulmonary failure only occurs in patients with very large curves, more than 100 degrees, but otherwise it will not affect the mortality for generally adolescent idiopathic scoliosis. The psychosocial factors are very important in patients, especially the adolescent patients. So in Iowa, 50 years follow-up series were done and showed that 32% of patients felt that scoliosis have limited their life, particularly with regard to buying clothes, decreased physical activity, and increased self-consciousness. However, patients with untreated adolescent idiopathic scoliosis show psychosocial and depression indices similar to the control people, to those of control. So there is no, real effect of severe psychosocial problem like depression on adolescent idiopathic patients. A very important question is, what about pregnancy in the future for females? Pregnancy doesn't increase the risk for curve progression in patients with adolescent idiopathic scoliosis and in patients who are having not a severe curve. Age of the patient at the time of first pregnancy, number of pregnancies, and curve stability did not affect the risk for progression of scoliosis. So, it will not affect the pregnancy. It will not affect also the choice, whether it's cesarean or normal vaginal delivery, generally speaking, in adolescent idiopathic scoliosis patients. So, in summary, we can see that the majority of patients with adolescent idiopathic scoliosis live a relatively normal life, able to have children and to work. Some patients may have increased back pain later in life, especially in the patients who are having lumbar or thoracolumbar pain, thoracolumbar curve, severe, and may affect psychosocial issues, including self-increased consciousness, trouble in purchasing clothes, and individualized decision for each patient must be made by taking into account the probabilities of curve progression based on skeletal maturity, sexual maturity, curve magnitude, and curve characteristics and age. Increased number of children are being referred for orthopedic opinion as a result of increased public awareness, National Scoliosis Association's screening clinics, a thorough knowledge of adolescent idiopathic scoliosis. Natural history is necessary for appropriate adolescent idiopathic scoliosis management, decisions, and proper patient education. So it's not equalized that adolescent idiopathic scoliosis means surgery. It might mean nothing to do. It might need just bracing or a conservative treatment, and it might need surgery. And we need to know the prognosis for each of them, and we need to explain that thoroughly to the family to understand where they are going to. Thank you very much.